Okay. All right. It is underway. Okay, so I can see Rosa and I can see Heather, so that is good. So we are getting started. Basically, what we wanted to do for you guys today is truly have a question and answer period for you as we get ready to roll out into resuming in-person HBTS and PASS. Really, as of next week, June 1st is Monday. So if we can make sure that our consents and notifications are signed and the families have the required cleaning supplies on hand, and we have all the PPE that our staff need with hand sanitizer and masks, and the families have theirs as well, we can slowly start to resume our in-home services. And with that, I know that there has been a lot of questions and a lot of thoughts around what will this look like as we roll forward. So I did want to use most of this morning or this afternoon as a question and answer for you guys to put out. We have Judy, Kim, Casey, Sean, myself. We have Deb and Melissa on board from nursing to help as well. So we brought in every resource we can think of to make sure that we're hitting answers for you from the medical and nursing department, administrative, and then, certainly a policy perspectives as we get forward. So before we end, I will, if our questions go long or our discussion goes long, I will cap it so I have time to go over our new office calendar that we'll be using for any office-based work that I'll review with you guys at the end, where we're at with our new employee orientation and NEO for the YFS group. I want to make sure that we're very clear on community outings and what that can and cannot do during our initial phase of rollout. So we'll go through that at the end. But until that point, I want to really open the floor to you guys, so you can field your questions. I can tell you this: you guys all got the version of what we are calling our consent and waiver for our families, and what we've recalled now is a notification form for our staff. On Friday, I sent those documents over to our attorney, Bill O'Gara, and he reviewed them over the weekend, and he had some minor edits that we have adjusted for both documents, and we have renamed the new documents as the final versions. Adriana is translating all of them into Spanish for us. Danielle will have them all translated into ASL for us. And they will be the documents that are going to the identified team members who have DocuSign, and they will be the team members that will be sending them to and from the families for signature and to and from our employees for their signature. So those are updated as of this morning and have been sent to your teammates and colleagues who are the DocuSign participants. And I will make sure that you get that final version after this meeting as well, so you can keep your own copy and see what's being distributed. But that did get slightly revised, nothing major. We were pretty much right on track from the attorney, but he made less is more. He took out a couple things and just really consolidated some of it. So it reads very smoothly. But
Bren, let me just speak to that for a quick second.
Okay.
This is Sean. I just want to say
that's what I had Jessica take.
When I spoke to Bill yesterday, he emphasized that the staff consent as we
she should follow a blank.
Hold on.
I may
Sean, hold on. Melissa, can you please mute yourself?
Schedule
Melissa,
them both for testing tomorrow.
Melissa,
I'll probably schedule them both for COVID testing.
She's clearly on the phone.
I know.
You can mute her.
Okay.
I will text her.
Thank you.
She's muted.
She's muted.
Okay. So what I was going to add, just plain and simple, is that the two documents, the one intended for the staff is renamed a notification, because basically, while we are asking our staff person to sign off on that, neither of these are legal agreements per se. It is a display of information. And when it comes to our employee, this is the way in which we're asking them to work and the parameters of their work in this part of our rollout. And so, you know, when you're able to take a look at that, if it's for the first time, you'll notice that our asks of the staff person are certainly within reason around guidelines, and they will either choose to work that way or not. If they can't honor, the consent that we present them with, then, they won't be able to move forward in the in-person work. But I do know that our managers who are exploring to the full extent the work that their staff is available to do, they're already disclosing how those members of our team will need to submit to testing and the other things that we would ask of them. On the parent and family side, the parameters outlined there are, again, our asks to the family. It would be what we need to be able to come back into in-person work. But on that note, the document itself does not contain every detail we would want to make clear, nor may it answer all the questions that the family has for us about returning to the in-person work. So I just want to say that if you view the documents and you feel like more could have put in one section or perhaps a point is missing, there's a lot of thought and effort has gone into the documents. They really do contain as much as they need to at this point. The rest of the information is that which you're going to be free to share with them when you have your conversations, when you answer their questions, and then what we may discover as we move forward. So I reassure you that the documents were written by a solid team here with nursing input, administrative input, and our lawyer took a peek at it. But really, to knock it out of the park, especially on the family side, the conversation that goes along with it is really important. And then the questions that they will have for us and your respective answers. So I'll just leave it at that. But that's really the context of those two documents.
Great. This is Brenda. Thanks, Sean. Okay, I'm going to open the floor up to any thoughts or questions or area of discussion. So if you would like to participate, I'm going to turn off my video and just turn your video on, and we'll go with first come, first serve for questions.
This is Deb. I just have a quick comment on the COVID screening tool. We've been updating that as we go to reflect the most recent developments. So it's quite possible that the COVID-19 screening tool will change. For instance, domestic travel will likely be taken out of it fairly soon. We're not doing it June 1st like Gina is, but I want you to know that will be, that's a living tool.
Okay, thank you, Deb. I also have a recommendation. At the bottom of the screen, there's reactions. And if someone would like to speak, if you want to just do the hand up one, then, there may be, say, 4 hands up. I can call a name, and then you can be the one to turn on your video and speak first. How about we do it that way? Karen?
Hey, Sean, how you doing?
Good. How are you today?
Good. Just wondering if we have a protocol in place, and sorry if I missed this, for bathroom use when staff are in the home.
A protocol for bathrooming. Can you just say the heart of the question again?
Yeah, I'm just wondering if there are specific protocols about the staff using the bathroom when they're in home, because normally I know a lot of staff stop at places on the way to use the bathroom, and that's not going to be really possible because of the precautions that all the business closures and stuff. And I wonder if there are special precautions that we're asking families to take or staff to take when using family bathrooms.
One of the things that we included in consent was the ability for staff to wash their hands intermittently or as needed while work is in place. I realize that can be at a kitchen or a bathroom sink. But when it comes to using bathrooms in family homes, I think that becomes a personal preference. In this time of COVID, I think that the ask is not clearly outlined to families, but I guess we have to take that into consideration.
Okay.
This is Brenda. We have our home profile forms that we've done over the past year and months of asking families which bathroom in their home that they're comfortable for staff to use. Hopefully our staff know, they look at that form and they know which family bathroom. If they're still not comfortable using a bathroom, hopefully if they feel that they have to stop on the way to or from work, There would be some establishment that may be open by the time we resume that they could go in and use a restroom. Other than that, if there are specific situations with specific families where staff are feeling very uncomfortable or they feel that hygiene's a problem, I think we're going to have to address those individually. I'm not sure we're going to have a bathroom protocol, although our protocols do ask that any commonly used area in the home, the families are working with us to wipe down and sanitize. So I think we'll just have to keep our eyes on that if there are situations that feel a little bit more problematic than others.
Sounds good.
I'm going down the chat list here, and Leanne has asked when the family consents will be going out, and will the screening tool be sent with the consents? Yes, that can happen. The consents were sent over to the DocuSign team members this morning so they can put them in a DocuSign format. So as they're hearing from you guys of which families need them with the email addresses, Danielle and Amy Shea will be doing the PASS families, deaf and hard of hearing families, and behavioral health families. They'll be sharing that workload. Shannon will be doing the EIBI families, and Emily, Karen, and Val will be doing their staff and employees. So they can certainly go out. I believe you guys all have the most up-to-date screening tool that I had sent out from Deb, but I can certainly send that again right after this meeting for you. And that way the staff and the families, what we do need to create, if somebody wants to take the lead on it, is our weekly sign-off sheet for the health screen tool that staff and families will initial, that will be kept in each home, that will be collecting with the daily data. So we do need a template for that if anybody wants to throw that together and send that around. That's one thing that has not been created yet.
This is Sean. I was going to do Melissa French's question, but Leanne, would you like to add more?
Just had a follow-up about the screening tool. I'm not clear on what that procedure is. I don't know if I missed it somehow, but you mentioned that there's going to be a form that has to be made, but I just wondered what's the actual process that we're expecting parents to do for that?
Leanne, is your question about the implementation of the screening tool itself?
Yeah.
Okay. So the screening tool is a one-pager that asks about symptomology and, have you left the country or anything like that. That form will be with staff and that form will be with families. They will address the items on the screening tool on their own each day that a shift will take place, and make sure that they are healthy before they leave for shift, both on the staff side and the family side. So it's going to be our clear expectation that if staff person addresses the screening tool in the morning before they're working and they feel like they have a couple of symptoms, we're going to ask that they not go to work and follow up with nursing. It may or may not result in testing. The same will be true on the family side. They will ask that question of themselves, maybe the primary caregiver, answer those same questions for all those residing in the home, and then they will call us to cancel that shift in advance if they discover that someone in the family is not healthy that day.
I want to add a correction to that. If there is one symptom that a person has, they cannot go to work. And anyone with any symptom is being tested. Just to clarify.
Yeah. And sick staff will contact their supervisor before contacting nursing. That was a comment that Deb added. Melissa French asked a question about community outings. So one of the things we will not be doing as we return to in-person work is putting youth in our cars and going places with them. We can do outdoor activities that are in their yard or nearby. So if there are things that are walkable, like a nearby open space or things like that, your children best. Sometimes they can access play equipment in their own yard, or they may have a bike, or the lesson may move outside during the good weather. All of that is fine, but what we're not doing at this time is going into the vehicle and going any place, whether it's near or far. So that's the bottom line on that.
This is Brenda. I just want to add to that. The reason why we're not going in staff cars for our initial rollout is we would then have to sanitize and make sure that all staff could truly disinfect and sanitize their vehicle. And we need to make sure we have enough cleaning supplies available to all of our employees before we ask that they're putting the kids in their car. So we're holding off on that. However, if families want to drive their child and staff want to follow and they meet at an approved community place, like an open soccer field or a basketball court, that's fine. They can do that. But you need to be mindful and work with your staff and your families about what's available in their community that's safe and open. There's some playgrounds that are still closed because the public playground equipment is a germ fest, and they're not opening some of that play equipment, or certain stores or certain areas that the child may want to go. So it has to be really an agreed upon safe and reasonable community outing. I know these may feel like long days, but remember, we're kind of in phase one of rolling this out. We're going slowly to make sure that we're back in there supporting families, but we don't want to jump into high risk situations unnecessarily. So, you know, making sure you're in good connection with your direct support staff, in your families, if they're going to start doing some community, what that looks like, what that entails, and have those conversations with them. Going down the question list here now, Deb Harbin, I just want to note, she had said that the residential programs already have a tracking template for the health screen that's in place and working well, so we can certainly grab their version and adjust it if needed to our home base. That way the families and the staff can initial it every day that their shift, so we know that that's a good working document, so that's wonderful that that already exists. Karen's question was asking if families can meet in the community, and we just talked about that, so that is fine. Carrie wants to know, how will families be held accountable? I have many families who do not disclose illness until after staff have arrived. Then they report that individual who is ill will remain in a separate room. You know, that will be challenging, Carrie. You know, we're really going into these reemergence of services kind of collaboratively and collectively, and hopefully on the honor system with families and staff for the safety of all. I think if we learn of those situations, then we'll have to temporarily suspend for that family and have a conversation with them and make sure that we have all safety parameters in play and a solid understanding of how we would move forward, to make sure that the staff are not at risk, or we're not exposing other families. You know, other than, you know, addressing it in the moment as we know it happens, we're asking if there is a family where you feel like that could be a problem, having a proactive conversation with them and explaining the importance of the honest report on the health screen might be a very good conversation to have. I'm sure you can find some sensitive but direct words to have with them regarding that. And then really empowering your staff to let us know immediately if they feel like they're in a situation where maybe that health screen wasn't answered honestly, and we'll have to address it, you know, immediately in the moment. Sean or Deb, I don't know if you have anything you want to add to that.
Yes, I do. Let's hold on. So a couple of things. First of all, I think that has probably happened prior to all of this anyway, and because I've gotten calls saying should the staff leave, and usually it's like a yes if it's like bed bugs or lice or whatever. So this is the kind of thing I would also do. And what I wanted to assure everybody is that Melissa has done a really nice job working with the Department of Health and can get anybody tested usually within a day, unless it's a long holiday weekend. So we could always send anybody, a staff in for testing if they wanted to. But I don't know that we have any more clear answers than that, because quite frankly, you know, we're kind of going forward. And I go back to Brenda. We already know that there are families out there that are struggling with a wide variety of issues. And those are probably going to be they're going to have the same struggles. That's basically it. Oh, can I just go ahead and answer some of the stuff on the chat while I'm here? There are pretty much no requirements for getting tested unless, if you tell us you want testing, we can get you testing. That because of where we work, what we do need is your date of birth, your zip code. The zip code hasn't been as important, but I think they're getting back to wanting the zip code for their data collection, and your cell phone. And generally speaking, we usually can get it done within a day. We're using, for the most part, for our staff, we're using open slots that the Department of Health has held open. And Melissa can chime in, but I believe it's like 1 to 4 and 11 to 2 or something on 11, like 1 to 4:45 during the week. And they're shorter hours on the weekends, like 11 to 2:15, I think.
11 a.m. to 2:45 Saturday and Sunday.
So you don't really need any requirements. And I'm going to say back when they were having us had requirements, Melissa's and my motto was everybody coughs once a day. So everybody had a cough and we just got them in. So, and the thing of it is they're really loosening that up because they want everybody, they want increased testing. And so thus they opened it up a lot more so that you could get anybody in. So when it comes to testing any and all of you guys, because I think that's where we are heading for, is getting everybody tested before you start working in the homes. And then we all know that you're not a symptomatic carrier, and we can tell the houses, the families that as well. We would need that information, and we're going to look to management to find some way of, we have templates that we already have. We can send it out to you, that you just have to fill in with all your names and the necessary stuff. Go ahead, Melissa.
I actually sent that template out to Brenda and Sean already, so they already have it to fill in.
So we just need that information, and then if people have, I don't want it, there's 41 people on here, whether we can have the druthers of 41 people as to exactly what day they want to go. I'm not sure we can do that, but we can certainly try to accommodate everybody. Like if you say, I want to go Monday, Tuesday, Wednesday, Thursday, Friday next week, we should be able to fit that in pretty easily. So you just need to kind of give us the preference too, but that, because of the amount of people, we're going to need management to kind of lasso that in somehow.
Yep, this is Brenda. So I think as we know, there are certain families and staff that will be ready to go. I think what we need to do is start prioritizing those direct support staff first. And I will send you those grids that you can complete with your direct care staff that need to be tested, and Melissa can start to schedule. And then the clinician and coordinator team that are assigned to those families, if we know that those families are the ones that are opening first, then we'll try to tackle it that way. So we're kind of rolling in as we go. Obviously, if there's an emergency family that we need to get out there right away and we need the clinician and coordinator tested right away, then we will certainly prioritize you to make that available and to have that support. But, we've got a little time to roll this in over this week and next. So Leanne's question is, will testing be done ongoing on a regular basis?
Not necessarily. That would not be our plan at this time, unless something changes, but we would not be doing it ongoing. I can tell you we've had people tested up to 7 times because they either had a tiny symptom or there was a question of whether or not they were positive. So at this point, testing is wide open and available for us. I don't see that shutting down anytime, but we weren't planning on regular testing. The only time we get into regular testing is if we get into positives or some exposure. So we wouldn't be doing that ongoing, but it's pretty easy to access.
Deb or Melissa, could one of you just give a quick overview of what the process is of when you're tested, what that looks like, what they can expect when they go?
Oh, it's kind of neat, actually. It's like sci-fi. Because it was worse when it was long lines. Now they've got it down. So when I went, it was maybe 30 minutes from beginning to end, maybe 40, and it was more waiting for the test results to come in. But you drive in, there's armed people, the National Guard there. They have you pull up. You can't open your window. You're supposed to put your license up or your form that you're bringing to the window. They may have you crack the window a tad so you can hear them. And then they tell you, put your window up, drive forward to the next place where they do another double check and they put a form on your window because they don't touch, the form comes and goes from your window, your testing form and your results. You drive into a covered place. There's a nurse there who has you crack the window again. She hands you the material to swab yourself with. It's 2 cotton swabs, and it's not like up to the eyeball. If anybody's gotten tested for the flu, it's very uncomfortable, and I don't even think you could do that to yourself. It's a good 5 swipes around each nostril, and you put it in. And you should really try to, get the snots out if you got them in there, because you want more material to make it a more valid test. You put it back in the little container, hand it to the nurse out of this little tiny window, and you drive forward and somebody tells you exactly where to park. And you do have to stay there with your windows up. So you want to make sure you have air conditioning on these kind of days, okay? I'm just telling you, you can't go sit there and crack your window while you're waiting for your test. They want everybody to stay isolated. And then they just come out and will tell you whether you're positive or negative. They put the paper in your windshield and you drive out of the parking lot. You can't stop your car to get the paper till you've left the parking lot. I'm going to caveat here. You should stop before you get on the highway to get your paper out of your windshield. We had somebody think they really couldn't stop to get it, and it didn't last the whole way home. But as soon as you pull out of the parking lot, there's plenty of places to pull over. You get out, you get your paper from under the windshield, very important, and save it. We need copies of that paperwork, and they really should be PDF. We can get pretty ingenious about taking a JPEG and scanning it and blah, blah, blah. But Mary Nunes keeps these all on file. But it really is pretty impressive. It's pretty efficient, and they know what they're doing. And I'm just going to say this right now. This test has been as effective, if done correctly, as all the other tests. Anything you've seen written was comparing it, or they were traveling with this. It wasn't a dry swab being tested right away. In our personal experience with all of our negatives and all of our positives, by the way, it has proven to be very accurate and on target. You could get more negatives because more asymptomatic people are going, and they may be going at the first sign where they don't have as much of a viral load in their nose. So I just wanted to make sure everybody knew that we're feeling pretty confident about this testing. And for about a week, the Department of Health also did dual testing. Like they did the one you do yourself, but they also offered the up your nose one to do comparison studies of the test. So I want everybody to know that we're feeling very confident about this testing process.
And I just want to add that if we do the grid testing where we fill out the grid and send it in, and you have that open time frame, not that specific, you have to have your Perspectives ID with you as well.
Okay. Thank you, guys.
Yeah,
I know Roger has a number of questions, so I'm going to let Roger come on next.
Hi, this is Roger. I have a few questions. One, is there any talk about plan extensions? I have 7 or 8 plans coming up in the month of June, going into July. If there's no plan extensions, what is the plan about getting the January, February data that is in all the houses? Because we didn't have time to get that due to the March crisis. And also, what is the plan for coordinators and clinicians to meet with the management team about the schedule? I know that Emily's job is crazy right now trying to figure that out, but it would be really nice if we could have a weekly scheduling meeting with her concerning where people are going and how we're going to train them. So those are kind of what's on my brain.
Roger, with respect to, oh, sorry, this is Sean. I'll answer the question about having conversation with management. I think that the managers have been able to go far and wide with reaching the employee group. I didn't speak to Val, but I had a conversation with Emily earlier today, and she already sits with some pretty solid statistics around the availability of people. She now knows that she has 27 staff who can be workers for us and agree to in-person work. You know, she was able to describe to them the parameters and that further detail would follow. She discovered some employees who quit. She is yet to hear back from approximately 5 people who are crickets. And then she did reach a couple of great people who, you know, a lot on this board would recognize as good staff who are simply out of state, but they want to continue to work for Perspectives and may come back to Rhode Island, just not sure when. And those people would absolutely qualify for some telehealth responsibilities. So we can work that out. And naturally, Val has made a ton of progress in reaching people too, and she could speak to her statistics even if she wanted to on this call or not. But I think from here and starting possibly by, you know, the end of this week, tomorrow, Friday, we could do some groups of clinicians and coordinators with the management leader to talk about what the plan is for disseminating the staff. I kind of take that back. I think this week might be a little premature because I'm not sure how far and wide the team was able to go with the full caseload and getting a response from families. I do know that a lot of people have been reached, you know, and we have probably a 50% green light on some in-person supports for most families we know. So I think that that's going to be a Zoom meeting, Roger, you know, and
Absolutely. Yeah, it's
the
just
extensions, I don't know if there are additional extensions, and I bet Brenda can answer the question better.
Yeah, so they're not right now. We did have an initial extension through May 31st just to allow agencies to recover a bit. I have not heard of any extensions, but I would not worry too much about that. You can still write your renewal or progress report and handle it a couple of ways. And remember that these don't get prior approved, so we're not submitting anything for a review. So you could put a note. I mean, you still want to write your treatment plan. You still want to update your renewal and your progress report for the folder. For the months of data that you can't report on, you can simply make a note that due to COVID-19, data from this date to this date is not being reported on in this renewal period.
Yeah, that's what I was trying to get at.
Nobody's going to take issue with that. You could always go back and put it in once we are back in the home and you have a chance to grab it.
Yeah.
So that's how I would handle that. But as far as I know, renewals and progress reports, you will need PAs to be kind of on the timeline moving forward because there's been no notification of an extension.
Okay.
Okay.
All right. And then as far as like the trainings go, I know there's been some talk about possibly doing, virtual trainings and vice versa, or maybe even watching the staff work from at their home by Zoom. And I'm sure we'll be able to figure that all out. But if that's the case, we're going to need Perspectives computers at homes for the staff to use.
No, Perspectives computers, no. It will be the same model that we're doing right now with our families for telehealth, that if the clinician or coordinator are going to log on and do telehealth to observe or supervise a direct support shift, then they will email the family the Zoom invitation, and the staff and the family will coordinate making sure that they can set up a way that the staff and the child are participating in their shift, and that the clinician can consult remotely, whether they're watching a certain lesson or watching a certain activity, or maybe doing the telehealth like they normally have with the parents on the side. You're going to have to get a little creative with that. I think there'd be scheduled appointments you guys are going to need to do with the family to let them know this is how you're hoping to operate. There'll be some instances that you will be on site with the staff person if there's a high need, but as much remote telehealth supervision and coordination that you can do, at least in this initial phase, to keep the traffic lower in the families' homes. That's what we're hoping for.
Right.
We're trying to keep exposure as minimal as possible because there will be homes that you have to go in. If you're training a new staff, or the child's having an emergency, or there's really a disruptive behavior that we need to get under control, there will need to be hands-on support from the clinical team. And we're hoping to save our traffic in and out of the homes for those situations versus if it's just a check-in or a parent training or an observation. And if we can still do it via telehealth and we can still do it remotely, we're hoping that we at least carry that out as much as possible. It's safety, it's efficient, we have the technology, telehealth is still fully approved at this point that we can do it in a hybrid model. So we're just trying to be mindful of number of people in and out of homes, at least in the initial phases as we roll back out.
All right, thank you very much.
This is Sean. Val had just asked a question about providing agency equipment to staff that are interested in providing telehealth. I strongly suspect that's not something we're going to be able to do. I think that would be a nice way to work, but agency equipment is been fully deployed, especially during this whole time of COVID. And I interact with the IT department on the regular, and that has come up as a question, for people like ourselves, who are working exclusively from home, and also acquiring equipment, is not fairly expedited, nor is there the budget for that. So unfortunately, we won't find ourselves providing additional equipment for staff that are doing telehealth.
Yep, and I can speak to, and when this first began, there were 3 computers, I believe, that we borrowed from the training room that we had loaned to 3 direct support staff on Team 5 because the scope of running their lessons and being able to access different materials was greater from our company computer than it was from their personal phone or their tablet they had. If those staff are returning to regular in-home work and no longer needing that, we could look to sanitize that equipment and move it along. Brian may need it back in the training room. I can't speak for it, but it's possible that if those staff are going back into the field, but we have other staff that are only doing remote telehealth, that maybe they can use those computers that were already loaned out if the inventory supports that. I can't speak for it, but we should look at numbers and look at resources. But at some point, I think all borrowed equipment is going to need to come back to the training room because we just won't be able to sustain that.
Brenda, this is Judy. Are we considering doing telehealth for direct support?
Yes.
If that's the case, Brian is expecting those computers to come back, but I think you have to assess if telehealth for direct support is part of this mix and part of the reopening. You should assess what equipment you need to be successful. And
okay, we can look to purchase maybe if we get funding for that. We've been able to access Zoom accounts from the agency for everybody that needs one. But if we're looking for actual equipment, we're going to need some numbers on that because I'll have to work that into the asks that we have from the state of our retainer fees and ramp up startup costs because that is not something we have in reserve right now, but it may need to come into play for funding to move us forward. So the sooner you can get me numbers on that, the better.
Emily pointed out that there is a grid that Amy has, which is up to date as of today, and it's in the same location as the family tracking sheet. So if you're curious as to who's signed back on to potentially do in-person work, we do have names.
Val is asking if those computers need to be returned, we just need to let the team know ASAP. I don't see that happening right now, Val. We'll make sure there's plenty of notice so treatment doesn't get interrupted. So we'll work on that on the side. I believe Leanne had a question that has not been answered about, I just want to scroll back up in the chat here, and Melissa did as well, that I want to divert to nursing. So Leanne's question is, are we having any limitations on the number of clinical team members who will physically work in each home if there is training or behavioral support needed? I think I would resort back to probably the cap of 2 people. Sean, I don't know what your thoughts are. We were trying to lay it out there'd be no more than 2 people in a home. I don't know if it's all 3, then the numbers are going to get high, but what are your thoughts on that?
Well, I think, limiting numbers is always important. I think we need to be conservative with our presence. we can have discussions if the feeling is that 2 people need to go into a home for training. The strong preference, I think, would be 1. The preference, again, always lies on the supervisor, but we've done excellent work relying on our coordinators and supervisors together, divide and conquer. And that's really my impression right now.
Right. I think that's going to have to come up individual. If there's a crisis that requires more than the supervisor or 1 person, then we will look at that individually and engage the parent in their comfort level of who's coming in and what our protocol will be. And then, you know, if there's any time that they wait before they go to another family. So we may have to handle that on a case-by-case basis. We're not going to have the perfect scenario for all 200 families, unfortunately, because there'll be some, there's variability here that's going to happen as we roll things back out.
So should the team members then contact their supervisor if there's going to be training to just sort of detail what the plan is? I'm sorry, this is Leanne.
Say that again,
Leanne, I was just following up on my question that if we have a need to do training or behavioral support that isn't just a crisis, but that might be ongoing, should we be contacting our supervisor to outline what plan we have? Like if we feel we need coordinators or consultants to join in.
Absolutely, yeah. Come back to Sean and Brenda. You know, we can answer a question like that, help make a decision or anything unique that comes up. Okay. Also, as we move forward, you know, we had talked about June 1st. We had even said, oh, there could be, you know, a family or 2 and we'd be rolling out this week. I mean, clearly this week is half over. That's not going to happen. Next week, I think that we'll see some in-person supports emerging. But my point here is that this is really going to be rolling out slowly but surely. And as we move forward in time, other standards are changing in Rhode Island around what the governor's expectations are based on the Department of Health and whatnot. For instance, June 1st is Monday, and a lot changes on Monday where things are more open. I think that they're going to increase the number of people that can get together from 5 to 15, if I'm not mistaken. We'll have good information on that day. It's day by day. But, you know, when we're trying to practice safely and we're doing a service that is in a home, it's you know, close to people's objects and stuff, we're really not interested in inflating those numbers. So my only point here is even as things start to change around us, we're going to continue to examine this service that we deliver to families and work within the safest parameters we can, which at some points may be slightly more conservation, you know, than what's going on around us. Health and wellness is the top priority. And that is one of the biggest reasons that we need to go back into the homes, because these are families who have chronic poor mental health, and getting back out there now is super important. And it's sort of in line with how our community is opening back up. But I imagine that we're going to exercise good discretion and conservation around contact until, you know, we begin to feel differently weeks down the road, if community health continues to improve.
I want to jump to Melissa's question, and then after Melissa's question, I want to use the last 10 minutes to go over the rest of our agenda, because I want to be mindful of the hour in our interpreter's time as well. Deb or Melissa, you may need to help us with your thoughts on Melissa's question, but her question is, if a shift is canceled due to the staff having a symptom and we send them for testing and they test negative, can they return to work once that system resolves? And what about the family? And what if the client or family member doesn't consent to testing? How do we gauge when we go back in?
Well, it's 3 days after no symptoms. If you're negative, we don't want anybody to go to work sick. And we have found in some of our positives that their symptoms actually may test negative and then they turn out to be sick. And so it would be 3 days after no symptoms. Regarding families, I go back to my stock answer. This will come up on an individual basis. Melissa and I are putting out the offer to try and be of some assistance to helping families get tested, but that will probably have some limitations just by virtue of they're not our employee, because we can truthfully answer that our employees are working, they're in a healthcare, they are considered to be a healthcare worker. And we have some employees who struggle with getting up to Twin River because that's where the testing is. So that may be a challenge. And I know in some of your hot spots, like your Providence, Pawtucket, North Providence, that they are trying to get more mobile testing sites. And I do believe there are there. We have not dealt with those. We can try to find out information to share with clients, but because we've just so focused on Twin River, we're well aware that there are community resources, but we haven't put our energy there because our energy's been kind of in perspectives. So a family refusing, we've had an employee here and there refuse to get tested. They have to go the 2 weeks. I think that it will be a case-to-case basis. I think that families who are not accepting help you probably already know who those families are going to be. We all know that you guys run the gamut from people who are really needy, but don't always take the help, from the ones who really want to work with you and get the help. So that would be one of those, cases that I can't answer now because we've had so many different scenarios come up with this COVID stuff that we do the best case scenario at the time with the information we have. It's not a very good answer, but it's the best I have. I don't know if you have anything to add to that, Melissa?
I think that pretty much covered it. I mean, I can't really think of too much more.
And this is Sean. So I think the summary to that response, Deb, is that when a family has presented with symptoms but refuses the testing piece, your request is that they generally self-quarantine for 2 weeks. That would mean no service or in-person contact. And then 2 weeks, we can evaluate how their symptoms went. We would be free to remain in contact with them during the 2 weeks, maybe for just a touch point, but then we could return after that safe quarantine time.
Yes,
exactly. But they would also need to be symptom free for 3 full days.
Yes.
And then that was our earlier question about staff. So even if they test negative, they still cannot return to work for 3 full days without symptoms.
We can reassess our requirements. This COVID has kind of put a lot of employee rights sort of off to the side where we can ask a lot more of people to work. But I try to go gingerly, and most of the people who refuse testing have subsequently been tested. So they can come around and we can maybe do education. Maybe that would be the way, but yeah,
because we have had a couple of people who said they didn't want testing at the beginning, who then eventually did have testing.
Okay. This is Brenda. Leanne has a question that how are staff who work on multiple teams being allocated to work with families? Again, whether it's multiple teams or multiple families, I do not believe, and again, Sean and Deb may chime in on this, we have not put restrictions on time limits. If you go to one family on Monday, can you go to another family on Tuesday or Wednesday? We did not get that concrete with an hour breakdown of we're trying to say don't go to 2 homes in one afternoon. But Deb, from a Monday to a Tuesday to a Wednesday, are you doing more than a 24-hour period?
No.
Okay.
But we have, and remember in the group homes, the 24-hour homes, we've had, it's been easier for us to say, because we have ample hours, that you can only work in one home. We've had a minute amount of exceptions in really kind of an emergent situation where somebody might have gone from one group home to work at another, but that is not, we are not encouraging that. We're not having it happen. And those people who are going from home to home are wearing pretty thorough PPE. Nursing, I've gone from home to home before, but I'm practicing what I like to call the ultimate in PPE, and feel fairly confident that what I'm doing is correct. So we're really trying to not do that. When I met with Sean and Brenda in the beginning, my question was, how do you have the staff? Do they want the hours? Will that even be something that happens? So that will go on. I mean, that'll unfold as the summer goes on, but we're not saying if you're assigned to 2 families, could you do Monday, Wednesday, Friday with one and Tuesday and Thursday with the other? Sure. But remember, we're really trying to drill in that everybody's doing the health checks, that we're doing good, that at the first sign of a symptom, we're all being clear with each other. So we didn't challenge that. And unless you have a family who is going to insist on that, I don't know how, I don't have an answer for that. If you're restricting to a number of families, it's the number of families.
Okay, this is Brenda. I'm just being mindful of our time. We only have 6 minutes left. I do want to say something about PPE, just to let you guys know, the personal protective equipment. We have given very large numbers to the state and request that they supply us with masks. We have also asked for a smaller number of face shields and a smaller number of gowns. We will not be going into a COVID-19 house knowingly that it's a positive COVID-19 house. But we have asked for gowns and a few face masks just in case we have a child that may spit or be, inclined to saliva, or may have difficulty with some hygiene. The staff may feel better with a gown on, or we may need a face shield. We've asked for that supply. Sean's been working with DCYF to get us some of those as well. If you know of any of your employees and our staff that need masks, we have some to get everybody started, and we will detail out a plan of how we can get those masks to them. I'll work with Deb and Jim and Sean on that. Maybe it's a curbside one afternoon pickup at the office, and we make up to-go baggies, and they drive in and we hand them their equipment, and then they have it as needed. It's a little more challenging than our residential home where we can just drop everything off because our staff are all over the state. So if we have, families that are struggling, we do not have enough for every family, although we've asked the state to give us some for every family. But right now we don't have enough for every family, but we do have some that if we have a family that's truly struggling and having that available, we could help get them started as well. So we will make sure that our staff and families that are ready to go have what they need so we can get treatment started. But that will be an ongoing quest that we're working with EOHHS to make sure we have the supplies, and we'll do our best to get them out once they come in.
I want to add one thing here, and I know this is going to come up in ADS as well. If you can't tolerate a mask, you don't have to wear a mask. If you have anxiety, and you can't wear a mask, nobody's requiring you to wear a mask. So you may run into a lot of people with mental health issues that you're going to struggle with. They say a desensitization program. We certainly need to work on that and encourage it. But anybody who can't remove the mask on their own should not be wearing one. If you have a little kiddo that can't use his hands, do not put anything, you can't wear a mask because you have to be able to remove the mask. You can't impede breathing. So there will be people who cannot wear masks for a variety of reasons. Certainly we work on the desensitization, maybe wear them for short periods of time, but we all need to face the fact that there are going to be people that will not wear masks and should not wear masks. If they have any kind of breathing issue, they should not be wearing a mask if they're on oxygen or something like that.
Karen, you have a quick question? You're on mute, Karen.
Yeah, my question was actually wondering about what do we do about kids who don't tolerate the staff wearing a mask, not them not wearing a mask. But...
Oh, that's pretty interesting because we've had a few people in the group homes that have been struggling with it. And we did a lot of, we have some social stories we've already used, and we have some really little flimsy masks that we kind of played with. because one person was really struggling because he was seeing everybody with masks till we showed him pictures and a social story of him wearing a mask and him understanding. So we already have some social stories about wearing masks. So, and that may be the case. And that would be a desensitization sort of thing. There's not many people that haven't seen people in masks lately, just saying.
This is Sean. Deb, that sounds like work that's already been done. If you want to talk to, I don't know if you hold them or some of the other clinical and, if they could come to our team, that would be great. But this is just the team to actually create those social stories, that we've been doing that for years. And we may have in fact already done that because there has been telehealth going on for a while now. But thank you for that. Appreciate it.
Do we also have access, Sean, to the masks? I talked to Brenda about this briefly, but I have at least one kid who's probably going to be more tolerant of desensitizing seeing someone else in a mask if we have the ones with the clear thing so they can see more of the face of the staff.
Thank you, Karen. I don't have an update on that, but there were members of our DHOH team working on those masks. There was discussion related to the clear mouth ones as to whether they were effective or not. I did hear the banter about some being effective, others not. So it looks like maybe Judy's emerged with a little more on that.
Yeah.
Okay, great, thanks.
Yeah, those masks are effective. I think like any mask, this is Judy, like any mask, some fit people better than others. But I know that Chaplin and Brook Lane had them. So I don't know if Jim's on the call, or Karen, if there's any excess around. If not, they're easily ordered.
Yeah, I just want to quickly add that Danielle is looking into ordering more for us, but we did order them for Brooklyn and Chaplin, and most of them worked well. Some of them had fit issues. One or two had some construction issues, but for the most part, it's a lot better to be able to see the face and the lip movement for many of our folks.
Great, thanks a lot.
Okay, I'm going to wrap up. What I'm going to need to do is a couple quick things. You will get an email and you'll see an attachment on the email that outlines our new office policy if you need to go into building C or into Dewey, upstairs in C or downstairs. There is also an attached cleaning checklist that you have to do once you enter and before you leave. And I'll give you a quick rundown. Basically, you will have to go, first you need permission from your direct supervisor of why you need to go to the office. Once that's approved, you'll go to the agency calendar. You will reserve a 2-hour time block on the day that you're hoping to go to the office. You'll have 2 hours to go in and do your task. If you need more than 2 hours, then you're going to have to sign up for multiple time blocks within that week. Only 5 people right now are going to be allowed into the office at a time, and only 1 person per office. So in the past office, I can't have Amy and Lisa. I could have one of them. Somebody can go to my office, somebody can go to Sean's office, somebody can go to the conference room, but only 5 people in the space in total. In the lead therapy station, only 1 lead therapist in that station at all times. So this will be clear that you'll see on Julie's document. And it also has 2 attachments that are from the Department of Health and the governor about the rules we have as an operating business in an office space about what we have to do to keep our employees safe. So this backs into a bigger Rhode Island business, bringing your employees back to an office setting safety protocol. So Abduli has 2 documents that you'll see attached that will be posted. You'll see our calendar protocol to reserve your time and your spot. You'll get a 2-hour spot. We will be having cleaning supplies available for you in the office to then clean the area that you were in. And Julie's checklist will walk you through that. And you do need to have approval from your direct supervisor of why you need to go in. We are really promoting that everybody continue as best as possible from working from home. And that we do know you may need to go in for scanning or making materials or entering data or something. And we're mindful of that, but we're asking you to try to do this as telehealth from your house as much as possible. So you'll see that coming out in an email. You will see the updated consents in the COVID-19 health screen, as Deb said, in the version that it's in now. And again, that could be ever changing throughout the summer. So you'll get updates from nursing and us as that progresses. You will see updates that we are starting our NEO training week in the youth division for the week of June 8th. And a quick snapshot of that, and again, we'll give you more feedback, is it is remote only. So our NVCI, our CPR, and our EpiPen, which are 3 hands-on trainings, are going to be via a video training only. So there'll have to be very good data keeping between the managers and the training department of which staff have gone through that training that's on the abridged version. So as soon as we have an in-person training option again, they will have to go back through and finish their NEO in full, the full NVCI, the full CPR, and the full EpiPen. So we are also writing a waiver that if you have to assign a brand new hire to a family, the families need to be made aware that their new employee is coming in with an adjusted training week due to the COVID-19 and sign off that they will be home and available for safety reasons with their child, because their staff will not be 100% trained in all 3 areas. So we have a waiver for that we'll ask. So we're asking, if possible, if we're bringing on a new staff person, that we're mindful of where we may be placing that staff person with any health concerns. And again, just a no vehicle transport at this time, which we've already gone over. So those are my bigger things, but we'll have to do the rest of this via email for you guys so you're clear. Any thoughts that you want to add, Sean or Jim, Deb or Melissa?
I think I'm all set at this time. If anyone has questions, please reach out in the way that you see fit. I will be taking the next couple of days off, potentially another day next week. I do want to get back on my supervisory track with everyone who I supervise here. We have been having meetings, but I want to get more regular. And Val, if you could just give me a call after the meeting. I'm sorry, I know you're in the room, but I have a question for you, that's all.
All right, thanks everybody.
All right, bye. Take care.